This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, everybody, and welcome back. Welcome back to the SimKit podcast. I am joined today by, this is a special guest, actually, for me, in Dr. Evie Marcolini. Evie has been a wonderful mentor for me throughout my career as I developed myself as an educator, as a clinician, and we've worked on many different topics in many different spaces together. If you look at the subarachnoid hemorrhage chapter of MRAP's Corpendium, you will see some familiar names included from this podcast. And she herself, she's an inspiring educator in the space of emergency medicine and neurology, particularly neurocritical care. And this makes her the ideal person to talk to today about our topic, which is the management of acute stroke in the community emergency department. Evie, thank you so much for joining us. Tell the listeners a little bit about yourself and your experience, your practice environment.
Thank you, Jason. And I could not be more thrilled to be here. I'm so proud of you and what you have developed. And it's just so great to see everything that you keep building and
Thank you.
And all the great work you're doing. So congratulations to you.
Thanks.
I tell people this all the time, and it is from my heart. I have worked in a tertiary medical center my entire career, and I've always got resources. The folks who work in the hospitals without those resources, the community hospitals, the urgent care centers, the very rural hospitals, are on the sharp end of the rope. They are the ones who are doing the hard work, and I highly respect you all. And I don't know if I could do your job because I'm so used to having all the resources available. So my hat's off to you all and my utmost respect for you. I finished emergency medicine residency at Maine Medical Center, and I went on to do a surgical critical care fellowship at shock trauma in Baltimore before we could board certify in critical care. After that, I stayed on as faculty at shock trauma and University of Maryland for 2 years before moving back north and going to Yale, where I worked in surgical critical care, emergency medicine, and then helped build a dedicated neurocritical care ICU. I stayed there for about 8 years and have moved on to Dartmouth, where we have started a neurocritical care ICU in 2019. And I still continue to work a 50-50 split, emergency medicine and neurocritical care. And it's a great split because I see the patients who come in the door in the emergency department. I see them go to the neuro ICU and then onto the floor. And it's a really good practice where I can not only understand what happens coming through the door in the emergency department, where we are the first ones to diagnose the patient and determine what happens in those really important first few minutes and the first hour, but then transitioning on to the ICU. And it's really helpful in my teaching because I have the perspective from both sides. I absolutely love neuro and neurotopics and emergency medicine, so I'm thrilled to be here talking with you about it.
Thank you. Thank you again for joining us, and thank you very much for your kind words. And yes, this is fantastic because, as I mentioned, this experience you have, it really does make you the perfect person to talk to about stroke care in the emergency department. Now, this stroke care has evolved significantly over the past 3, 4, or 5 years with the evolution of endovascular therapy. I kind of joke, and I do sort of see, like, the neurologist, they have been searching for decades, really, to find an effective and active treatment for stroke. And we'll talk about TPA or TNK in a moment, but it appears that we really have found one. Now, granted, this is for a select minority of patients in endovascular care. Now, while this is great for patients and this disease process, it really has made management of stroke in the community setting much more challenging and complex. So with that in mind, Evie, I want to talk about how you think community hospitals should be structured and how providers should be acting in these settings. How's that sound to you?
Yeah, that's really that's really important to think about, and let's talk about that. In 2015, before 2015, we didn't have FDA approval of mechanical thrombectomy. We didn't have evidence that showed that it improved outcome, but we were doing it all the time. There were so many patients who were having thrombectomy, improving their outcome, and having great outcomes from it. And it wasn't until 2015 when we had the Mr. Clean trial that showed improved outcome, and then the subsequent 5 other trials that corroborated that. They all closed their books early because there was overwhelming evidence that mechanical thrombectomy improved outcome. Well, that's great. And it helped us to pursue that. But what it did is moved the needle, because now when patients come into the emergency department, not only do they have TPA, which we've argued and paddled for decades over, but now we've got something that really has great data behind it. And that makes it so important to be acting quickly and diagnosing and treating and getting the patients to the angio suite to improve outcome, because time is still brain with thrombectomy, just as it is with systemic thrombolysis. So that puts the onus on us in the emergency department, wherever we are, to understand what's going on, to act quickly, and to get the patients where they need to. So if you're in the community and you don't have neurosurgeons that are doing endovascular thrombectomies, you've got to get them to that place. The other thing that has happened is it brings up the question, should we still be giving TPA? Should we still be giving systemic thrombolysis in the patients who are going to have mechanical thrombectomy? The short answer to that is yes, it still is the standard of care to give patients systemic thrombolysis even as they're on their way to mechanical thrombectomy. And we can talk more about that later if you want. But what this does is it pushes the decision-making out to the pre-hospital world. So folks who are picking patients up, diagnosing stroke, and trying to figure out, do I go to the closest hospital or do I carry on to the tertiary care center where they can do mechanical thrombectomy? It complicates the decision-making, to be sure. And there are systems in the country that have diversion protocols and have worked together to figure out which patients should bypass a local hospital to get to thrombectomy. Not all systems have that. And it's really complicated and intensified the work that we do both pre-hospital as well as in emergency departments to get these patients where they need to go.
Yeah, and I'm glad that you brought up that pre-hospital element, because that is an additional wrinkle there. I mean, there are so many decisions or decision points that need to be made as a provider that we're going to get to in a moment that you have to do in moments, right? We have to score them on 2 different categories essentially and think about their likelihood of having an LVO, large vessel occlusion, as well as their candidacy for TNK TPA. So there's a lot to do and there's a lot of branch points. And then as you mentioned, there are those that get both. And so making that decision in the back of an ambulance with limited information makes that even more challenging. Now, you can't be diverting all patients with stroke-like symptoms to your tertiary center. So there has to be a balance, right? There has to be a balance and a mix there. But first, Evie, I kind of want to start with the brass tacks of stroke, the basics, the basic care, if you will. So with that in mind, I want to paint a picture. I want to tell you about an 85-year-old female. She comes in via EMS with dense left hemiparesis and garbled speech. The family noticed that Mima just didn't seem right after breakfast, so naturally, they put her down for a brief nap. She woke up about 2 hours later and they noticed these deficits. So now we're at the 3.5-hour mark from last known well. Well, Evie, tell me about your approach to this patient with the pretense that you are now working in one of these freestanding emergency departments, but one that does have CT capability.
That's a great case. So I know that I'm 3.5 hours out from last known well. So I've essentially, I have an hour to work with of the systemic thrombolysis window. So the first thing I need to do are the basics: a finger stick glucose, do an exam, get her to the scan. Those are the three big things. Get her to the scan to make sure she doesn't have a bleed. I think it's interesting in this case where the family put her to bed because they said she didn't seem right, because it's pretty common that an 85-year-old female might not seem right, and it might just be because she's fatigued, hypoglycemic, has a UTI. There's so many other things that can mimic stroke. So it's not really that unreasonable that the family put her to bed for a couple of hours. Thankfully, she comes in at the 3.5-hour mark. But I'm trying to figure out, does she have a bleed? If not, by my exam, does she qualify for systemic thrombolysis, and getting that on board as soon as possible, even though we're at the tail end of the 4.5-hour window.
Yes, and not to mention we have that sort of another hour to that 4.5-hour mark. But the second that they hit your door, you also have your own internal timers, if you will, your own systems-based timers. And we have 20 minutes to CAT scan, the time window for ourselves as an example. So you're not only sort of competing against the clock of systemic thrombolysis, you're also trying to work within the metrics within your system, so long as you're doing, best by the patient, obviously. You're trying to meet these numbers as well. So there's kind of two ticking clocks that you have to consider.
Yes, and I will also add that you have to find out if this patient would want thrombolysis were it offered. If you could offer it, would she want it? She may not be able to tell you. In this case, she's not going to be able to tell you whether she would want it. You have to find out who her close family is, who is her DPOA, who is the person who's going to be a surrogate decision maker for this. Now, I'll tell you, there are folks who argue that systemic thrombolysis is the standard of care, thus it doesn't need consent. I am not one of those people.
Yeah, agreed.
This is a procedure. This is a medication that has risk, and it does need to be consented. It is, if you cannot get consent, then either by the patient or can't find family members, then it's reasonable to give it because it is the standard of care. But we need to make every effort to present this as an option to patients and or their surrogate to obtain consent for it. So you have to find the family and clarify, when was the last known well? How did the story go? Because oftentimes the story changes when you actually get to the people who were right there with her.
Yep. Yeah. No, I totally agree. I think it's not without risks. And we actually may possibly get into this later in the podcast, but I like being present during the consent process because I think it's nuanced, and not to say that I don't trust our neurologist to really outline them, but you don't want the risk to be glossed over. You want to make sure the numbers are truly being presented in terms of bleed risk, mortality risk, if bleed, etc. Now, in that space, Evie, just to go over this case a little bit more nuance and detail, we have a stroke stop in our department. You stop before you transition into the bed so you don't have to transition them back out and all the delays and details that come with an EMS handoff. If you can tell me about what you're doing at bedside or at stretcher side in the hallway with this patient. Do you have specific scores that you're referencing or doing, and how are you coordinating that with the general approach with what you're asking your nurses and techs to do?
Well, what we're doing is getting a quick exam. We're not doing a full NIH stroke scale. We're doing a neuro exam to figure out, does the patient have a large vessel occlusion? Clearly, if they have stroke symptoms, as this patient does, they're going to get a CT, and we're going to consider whether or not they should be offered systemic thrombolysis. But it's not the entire NIH stroke scale that we're doing. We're doing an abbreviated neurologic exam.
Perfect.
And that's the first step. I'll tell you that there are some systems, and I'm glad to hear that you guys have a stroke stop in the hallway. Some systems are going directly to CAT scan, getting the exam along the way and the finger stick, getting an IV in if it's not already in, and getting that CAT scan as soon as possible. Some systems are also pulling up the systemic thrombolysis, whether it's alteplase, because that alteplase needs to be mixed, right? And they're pulling it up right away. And I think that's great. It's a time saver. And if it doesn't get used, it can be replaced. It will be replaced by the company. That's all time savers. When we think about stroke, we think about how can we shave off minutes. Some systems are still not doing that. I will tell you that my system is not doing that. We take our patient to the room, we do the exam in the room, then we order the imaging, and the patient goes off to the CAT scan after that. And we're not getting the TPA drawn up and mixed until we know we're going to give it. There's many reasons why some systems don't do it that way, but I think that shaving those minutes is really helpful. So what you guys are doing is great.
Thank you. Yeah, I appreciate that feedback, and I agree. Anytime you can save moments, and it's an aggregate of moments, it's the opposite of death by 1,000 paper cuts. It's getting to your numbers and metrics as quickly and as efficiently as you can. I'm going to give you kind of my bedside approach, and then I'll ask for your feedback on it. How's that sound?
Great.
So we often will, and when our patients come through private vehicle, our numbers are worse, 100%. We need to be better at recognizing stroke symptoms when private vehicle arrival. But we're going to talk about the EMS. So in the EMS sort of alert via radio, they will often tell us that they have a patient with stroke-like symptoms and that they are looking for a stroke assessment or a stroke alert. With that in mind, we'll often let our CAT scan know right away so that they can complete the last study and have the table held for the patient. When they come through the door, I'm working at bedside. I get the EMS rundown, particularly questions about last known well, if they're on a thinner, any other information related to trauma. After that, while our nurses are trying to get our first set of vitals and our blood sugar, I'm doing our fast ED assessment. I'm doing that scoring because our system works with that for differentiating concern for LVO. And it is integrated, and parts of it can be utilized in your NIHSS later on. So I like that system. I'm doing a fast ED assessment, looking to see if we are at that 4 or greater point, which we're marking concerning for LVO. Once I get my fast ED completed, I'm leaving patients' stretcher. We are having a tech bring them to CT, and I have to hop to the computer to put in the order for our imaging, which includes generally a CT and CT angio, and the sort of laboratory work and other things that go along with that. This includes a page out to our telestroke system if we see a patient that we think is in the right window, a good candidate for TPA, etc. After that order is in, I meet them in CT. CT is completed, and I complete the remainder of my NIHSS at the bedside in the CAT scanner. After that is done, the patient's brought back to their room for the remainder of their sort of assessment, making sure that the labs are appropriately drawn, the person's on telemetry, we're getting a cycle. Particularly important, obviously, is the blood pressure, so that we have that information for conversation with our neurologists. From there, I'm usually getting a page back on my phone from our stroke neurologist. We have the computer at bedside where we can do telestroke, and we do the NHSS together and determine the appropriateness of, we use TNK. So that's kind of it, start to finish. What are your thoughts?
I love that. I've taken some notes, and I've got some thoughts and also some questions for you. The stroke alert is really helpful. I agree with you. It's harder to do this. It's harder to get the wheels moving when the patient comes in by private vehicle. We all suffer with that problem. And holding the CT and getting all the wheels moving. Do you page yourself, or is there somebody who pages that when the stroke alert comes in?
We have a tech that calls our CT operator and lets them know we have a potential stroke for the hold.
That's great. We do the similar thing when the stroke alert happens, a bunch of things happen all at once. What I think you have as an advantage, Jason, is when our stroke alert comes in a tertiary care center, the stroke team comes down, but the emergency department team has started the exam. And often there's this little dance. Well, the ED resident has started the exam with the attending standing there. And then the stroke team comes down, and the tendency is, okay, step aside, let the stroke team do the exam. And we're always trying to just get the resident and the ED team to continue that exam. And if there's any questions, the stroke neurologist can ask those questions and maybe finish parts of the exam that they hadn't seen. So we tend to waste a little time there. When you are and you're doing the exam and making the decisions, I think that's a good streamline that you may not have been aware of. It really, you have an advantage there. And with respect to placing the orders, you're doing that. It's similar. I think that's the best you can do. You've got to figure out what you're going to get. Are you going to get CT or CT and CTA? The FAST ED score is great. Whatever score you have and that your system uses and recognizes is the best. One of the things about stroke care and keeping it streamlined and not streamlined and efficient is doing the same thing every time and having everybody in the room understanding what's going to happen, so that everybody knows this. And when you know this from your company that teaches people how to get their muscle memory going by doing procedures, the workup of stroke is the same thing. It's muscle memory, and it's muscle memory for everybody in the room. And if 90% of the people in the room know what's going to happen next, it will happen and it'll be efficient. So the FAST ED score is fine. Sometimes I talk about the VAN score from a study by Teleb back in 2016, which is pretty simple. And it consists of asking, how weak is the patient? Can they raise both of their arms? Do they have aphasia? Or do they have neglect? Those three things. If they have weakness plus one or all of those three things, they're VAN positive and considered to be likely to have a large vessel occlusion. But it's any system that you have that everybody understands is going to be the best system. And contraindications are a question as well. I have seen some systems that have different contraindications that are based in experiences that they have had. So there are the published contraindications, and you could just look at those on your MD Calc. But the ones, whatever contraindications your system uses, the point of it is understand what your system uses, know them, have them tacked up on the wall or in your pocket on a laminated card or something. Know what they are, because that's the standard that you're going to be held to. And I say that, and it sounds like I'm starting to talk a little bit about liability, and I am, because stroke is one of the highest liability cases in medical malpractice for emergency medicine. So we need to be aware of it. And when we talk about standard of care, we are held to the standard of care that our hospital system uses. So contraindications are basic, and they can be nuanced as per your hospital. And the question of CT versus CT and CTA is one that I've talked to a lot of people about. I feel that getting a CTA is something that we should consider. It's extra radiation, it's extra cost, it's contrast that an 85-year-old person who doesn't have kidney problems yet may not really need, and we need to be thoughtful about it. There are systems and folks that I've talked to who get CT-CTA for every stroke. And the way they justify that is that they say it's not really a lot of contrast. It doesn't usually box the kidneys, and it's very efficient on the side of efficiency. Those are folks in high volume places. I think if we're in a place where we can take the time to make the decision on whether or not we're going to get that CTA, we should. In our center, we do take the time to make that decision. It's not everybody that gets a CTA along with their CAT scan. The other thing that I wanted to bring up is, do you ever just give TPA without getting teleneuro involved?
That's a great question. I would say generally no. We have a robust enough system there where we have time. By the time that we have our CT and or CTA completed, we have the ability to assess it. We have our full NIH score that we are in consultation with teleneuro. Now, if there were a operation or system where that were down, there's IT problems, technical issues, or we can't get the computer system to work, we would probably default to a phone conversation. But in a hypothetical where we have no contact at all, say they're already actively involved in the case and just can't get themselves to our patient, we would be in the right to make that decision independently.
Oh, that's great. That's really a great resource that you have. I think that emergency medicine is really good at looking at the big picture. Neurology is really good at looking at the stroke picture.
Yep.
But one of the things, and you may have seen this before, are patients who come in looking like they have stroke, but what may have been overlooked is the fact that they have alcohol on board, or there's something else about their story that is making this a mimic for stroke. Emergency medicine is really good at looking at the whole picture. And we all need to be thinking about mimics. Is this patient seizing? Is that a possibility? And getting the rest of the story from the family.
Yeah, thank you for bringing that up and also giving us that sort of liberty to be the bedside clinician, and the clinician that generally can think with a broader scope, wider binoculars, if you will. Because, yeah, you may not like this, but I am not totally on board with systemic thrombolytics. I do, in very clear, down the pike, right down the fairway, obvious stroke symptoms, obvious time window, I think it offers the patient the best opportunity for a good neuroprognosis. If there's wrinkles, complexities, other etiologies, if we're thinking alcohol related or Tau's paralysis or anything else in that space, I'm often considering that, talking about that, putting a time stamp in my note about why we need to further delineate the potential etiologies before giving this potentially harmful drug. So yes, I agree wholeheartedly. And find it validating that you see us as the folks that are best apt to really look at the whole picture and potential other etiologies.
Yeah, let's talk about that. And you say I might not like it, but no, I completely respect that opinion that you just expressed, Jason. I really do. And I think that we are the ones that can help prevent giving TPA to stroke mimics. And the other part of that is that we've been arguing about TPA for decades, literally decades, and we continue to argue about it. One thing I will say is, if we're not going to give TPA to a patient, it should be because we have a contraindication, or the patient doesn't want it after they've been explained what it is and what the risks and benefits are. And it's always beneficial to bring a neurologist on board. Too many times I see emergency physicians get in trouble when they make these decisions solo, and there can be consequences later that none of us wants to face. And this is the reality of our world. Even if we agree that the evidence for TPA improving outcome in somebody with a large vessel occlusion, or even with a minor stroke, is not great, the standard of care is such that we are held to it. And I think we need to protect our patients by explaining to them really well what are the risks and benefits, but we need to protect ourselves by understanding what our hospital policies are and what we are expected to do, and hold to those. But if we're not going to give TPA, which I don't support TPA in every case, if we're not going to give it, it's got to be documented well and have a good reason. And it's always a good idea to bring neurology on board with that decision.
Totally. Completely. That resonates super well with me. And if you look at the stuff by Mike Blindstock, or you look at any other things that set you up for litigation, I don't love to talk about that stuff because I think that is not our focus, right? We need to focus about quality care. But while we're providing quality care, we also want to be able to practice for a long time and not be in the middle of a legal battle that can extend out for many, many years. So in that same space, as I mentioned, when we're talking about and having those conversations and there's lack of clarity about, last known well, or if the patient actually had a fall, or if they're taking their anticoagulation, all of these things are things that I'm time-stamping, documenting in my note as to why. And even in patients that it doesn't suggest an LVO, or their imaging confirms it's not an LVO, and they're at that, 4.5 hours, say they're at 5 hours, still having the conversation with family, like, I know that there's often talked about, or you might have heard about clotbuster medicines. The reasons why we're not using it in this circumstance is X, Y, and Z. And having that conversation and having it documented, I think, is a hugely important factor in the care we provide just to protect ourselves.
I couldn't agree more. That you stated it quite well.
Thank you. All right. So I wanted to come back a little bit to, we were talking about, you can use the VAN score, you can use a FAST-DD score. Eventually you're getting your NIHSS. As they come back and go through that, thank you for bringing back up anticoagulation, or sorry, the thrombolytic questions, right? We need to further delineate their candidacy and the risks associated with it. So for our hospital system, we kind of have the quote unquote 3 thrombolytic questions. The first is, are they on an anticoagulant? And really here we are considering warfarin, dabigatran, and 10A inhibitors. And then any recent surgeries, trauma, or major procedures. The definition of recently, I feel like that does evolve or will be variable by hospital system. So just make sure you're aware of that, where your system and where your neurologists are putting that number. And then any history of bleeding issues, coagulopathy, and or major bleeds like an intracranial hemorrhage. So Evie, what do you think about these questions as kind of good or not good screening for thrombolytic candidacy?
I like those questions. I think that works quite well. And the other thing that we're doing in emergency medicine is we're getting the patient's history. We're not just focusing on the questions that would disqualify them for thrombolytics, but we're getting their history to see if there's any other nuanced things going on that make us feel that either A, it's a mimic, or B, it's a contraindication. So if you go through a complete list of contraindications, getting a good history is going to pretty much cover all of those, right?
Yeah, true.
Yeah, and
That's
you'll find those things.
Okay, good advice. Get a full history. Talk to the patient. A dying art in medicine, probably just right behind an actual physical exam. All right, so Evie, we've sort of talked a fair bit about our initial from the hallway stretcher assessment, the readiness of the system for rapid CT, getting in touch with your neurologist, some even of the medical legal aspects of talking about and consenting patients for thrombolysis. And then we talked about the true contraindications to thrombolytics with these questions. But there's a wrinkle of complexity for me that comes with the NIHSS. So I talked about the FAST-ED, and if the FAST-ED score is greater than 4, that is an indication or a sign that the patient might have an LVO. But the NIHSS can also have a duality to it, if you will. So as I mentioned, sometimes I'm looking for or trying to identify patients that may not really benefit from systemic thrombolysis. And one of the ones that's in my mind is people that have low NIHSS, typically talked about as a score under 4, obviously recognizing or considering the degree of disability from the deficits that they're getting scored on. So low NIHSS might be a relative contraindication to TNK or TPA, but then there's also the reality that the high NIHSS, so if you score someone and they have a score as 6 or greater, as a potential trigger point for considering LVO. So kind of complicated, a difficult thing to work with. Evie, how do you rectify these kind of competing interests in the NIHSS?
So I'm glad you brought up the NIHSS, and I'm going to take the liberty here of first talking about the NIHSS. I think we all know that this was a research tool developed, and it really evaluates patients for the anterior stroke, and it's the most common stroke. But I can't resist taking the opportunity to talk about the fact that you can have an NIHSS 0 and have a posterior circulation stroke that is significant. So let's not forget that. We are putting more focus on the posterior circulation stroke now, and I think it's bearing fruit because we're starting to recognize that some patients who come in with dizziness actually have stroke. And when we're talking about the cutoff points, when you talk about less than 4, less than 6, greater than 6, I think we should be looking at what actually are the deficits. I can remember a patient that I had with an NIHSS of 1 who had isolated aphasia. And we gave her TPA and she got better so that she could speak. She was a young woman who it would have been devastating if she couldn't speak. And so thinking about a score really doesn't get specific enough in many cases. So if you're saying to yourself, I'm not going to offer thrombolysis because the score is low, that's one of those times where I think you need to bring somebody on board to help you support that decision. Because somebody could have what oftentimes gets referred to as a minor or non-disabling stroke. That might be minor or non-disabling to you or me, but maybe not to that person. So I'm not a big fan of saying if a score is less than XYZ, we're not going to offer. I think it has to be done on a case-by-case basis.
Yeah, I like that approach, and I think it adds a simplicity and more of a whole picture mindset, like we've been talking about, which is really important. Like you said, you can have low NIHSS, and I've had those cases as well. As I mentioned, I'm generally trying to find ways to wiggle myself out of going down that pathway. But people with a score of 1 or 2 who have profound dysarthria or who have, dominant arm weakness, and honestly, it doesn't matter what your occupation is. If your dominant arm is no longer functioning, you're still getting a relatively low score, but the deficit is pretty profound and devastating to you. So I like that idea of thinking about where the numbers are coming from, where people are scoring in. And I'll tell you that in my clinical practice, some people have had slightly higher scores. I'm not pushing above 4 generally for this, where there's a lack of clarity, there's some inconsistent elements. The symptoms are largely sensory with no pronator drift, no motor weakness. And those, to me, I feel comfortable on my own in some capacity making the decision saying it's a low NIHSS score. It's related to a sensory change as opposed to motor or something that would be non-disabling in that space. And for that reason, we are, the risk-benefit profile for TNK is to not move forward so long as we're completing a shared decision-making with the patient or their proxy.
I agree. And you bring up the sensory. If somebody has an isolated sensory exam finding, we have to think about what, you're going to get imaging, but we have to think about, is this really a stroke?
Mm-hmm.
And that can become somewhat of a tricky question to discern. And those patients really are going to get neurology follow-up. They should, because you don't know. It could be isolated sensory. So it's really good to bring them on board with that. And the other thing is, sometimes I see people saying, "Oh, I've got this patient who's got right hand sensory deficit and right shoulder weakness and left arm sensory deficit, and you really need to put that together and say, does this make sense anatomically? And if it doesn't, then it's probably not a stroke.
Yep. Agreed. Totally agreed. And I forgot to put in my little jab or joke about how there's neurology data out there about giving systemic thrombolysis to stroke mimics, and how it says, well, it's not so bad because their bleeding risk is lower because they actually didn't have a stroke. I don't buy into that. I'm not drinking that Kool-Aid personally. I think we have to continue to think critically, like, does this make sense in a brain anatomic situation? And not just say, well, if I give systemic thrombolysis to a non-stroke, their bleed risk is lower, so I can go ahead and give it to everybody. But I like this area of conversation about the nuances of the NIHSS, and I'd like to kind of transition it slightly into this idea of dual antiplatelet therapy, because this is, come through in that 2023 article about lower stroke scores generally collectively not thought to be disabling to the patient, and having equipoise, it seems, in the treatment of strokes with dual antiplatelet versus thrombolysis. So possibly another arrow in our quiver for these patients. And Evie, I just want to know, are you using this therapy? And if so, how?
So Jason, you're talking about the Aramis trial from 2023 that looked at DAPT versus alteplase for patients with minor non-disabling stroke within 4.5 hours from symptom onset. In that trial, that was defined as an NIH score of 0 to 5, with 1 point or less on single item scores such as vision, language, neglect, or single limb weakness, and a score of 0 in the consciousness item. So if we go back to chance and point trials from 2013 and 2018, they showed us safety and efficacy with DAPT in acute minor stroke or TIA. And the Aramis trial asks, well, why not alteplase? And it was a multi-center, randomized, open-label, blinded endpoint assessment, non-inferiority trial. They enrolled 700 patients, and they showed that DAPT was non-inferior, with the primary outcome an excellent functional outcome of a modified Rankin score of 0 to 1. They also showed a secondary outcome that fewer patients in the DAPT group had early neurologic deterioration. They had fewer adverse events of symptomatic ICH and other bleeds. So with that study, it is a non-inferiority trial. And I'm no statistician, but I don't think that one trial shows that we should change practice. And I don't believe that the practice has changed. Will it in the future change if we get some larger studies and look at this and find out that DAPT is just as good as alteplase for this? Probably.
Okay.
And I think my answer then to your question remains, it's a non-inferiority trial. So if you're giving DAPT because you're not giving TPA, I think the first decision point is, are we giving TPA? And if you decide with teleneuro, we're not giving TPA, then I think DAPT is the standard of care.
Interesting. Okay. Yeah. I like that. I like that thought process in a branch point decision. And it's a little bit different of an algorithm, I think, for you than the way that we've talked about it or even used it in patients with these low scores, non-disabling symptoms within a window for TNK or thrombolysis. We are sometimes talking about this as like, do you do one or the other? I appreciate your branch point conversation more of, are we talking about systemic thrombolysis? Yes or no? And then if you're in the no category, then you're talking about utilizing DAPT.
Yes. And also, after that first branch point, if you decide we are not giving TPA because it's non-disabling or minor stroke, then you are going to be getting an MRI and making a decision to give DAPT.
Yep, that makes sense. And the speed with which you operate for DAPT is very different than that for TNK. So I appreciate that answer and that slight alteration in sort of mindset or mind frame, the way you're asking yourselves those questions. Perfect. Thank you. All right. So now, Evie, as we come toward the end, let's talk about it. Let's talk about the LVO realm. We're going to come back to Mima. Mima, who went to bed, came back, wasn't right, has dense hemiparesis on the left. Let's say that patient, upon your assessment, she has a FAST ED score of 5. How does your approach differ when LVO is on the table, saying we're still in the window, say she's still coming in at 3.5 hours?
Well, everything we talked about with regard to the process of getting the patient to the scanner, determining that she doesn't have a bleed, and getting finger stick glucose and the exam, etc., applies. But if I think she has an LVO, I'm going to get CTA. I'm also going to make sure, which I believe we've already covered, that somebody's calling to see if we can get them to a center that has thrombectomy capability. The other thing, and I've heard some systems talk about this, is, as you know, when EMS brings the patient in and you're doing everything that you do, if they leave and then you determine you want to ship your patient 45 minutes up the road, you need to get another EMS rig to come and transport your patient. If you think there's an LVO and you have the opportunity to ask EMS to stay, because then they can just take the patient right up the road to the endovascular center, that's going to save time. That's going to be very efficient. But I think where you're going is, when I know that the patient has a score that says probably an LVO, I'm going to do everything with the anticipation of transporting to that center.
Perfect. I like that structure and that thought process. And it's another opportunity for listeners to think about their systems-based practice, right? If you have a transport team that's bringing a patient in and they are there doing handoff, you're doing your FAST ED score or your VAN score, recognizing high probability for LVO, you're going to scanner, you're getting your CT, probably CTA, you're getting ready and administering thrombolysis. That is not a long period of time. And having them available to complete transport to get to EVT is a great way to have that system in place. You do have to make sure that your EMS directors are on board with that process, but a huge time saver for transport up to EVT. And we've definitely hashed this out, but just to say it aloud further, you are still, I know there's data about and conversations about if someone's getting EVT, do they need systemic thrombolysis? You're still thinking with the same cap, right? If you're in that 4.5 hour window and you've done all the things that you are supposed to do as a practitioner, you're confirming that this is indeed a within the window stroke, you're giving your systemic thrombolysis as you prepare for the next step for the patient, which is EVT.
Exactly.
Excellent. Now, let's talk as a wrap up about how you manage these patients. Say Mima comes in at 6 hours. So how do you approach her if she's no longer in a systemic thrombolysis candidacy realm, but you do your VAN or your FAST ED and you have a high concern for LVO?
Yeah, and I have pre-hospital roots, so I always like to go back to the pre-hospital in a question like this. If the pre-hospital team suspects that there's LVO and they know that they're past the 4.5 hour window, there has to be there should be, or it would be great if there was some kind of a systemic support to say, bypass the local hospital and go directly to the tertiary care center where you can get thrombectomy. I think that's not the case in most systems. I don't know if it's the case in your system, but that's a huge time saver if they can do that. And clearly, when we're at 6 hours, we are out of the window without question for systemic thrombolysis, and we would apply all of the imaging, exam, history, etc., that we're doing to figure out if we think this patient is having a stroke. We're doing all the same things, but we're focusing on getting them to a place where they can have the opportunity for thrombectomy.
Perfect. I love that. I like that process. We talked in the beginning about how you can't be sending all of your stroke patients to the tertiary center. They're going to be inundated and get poor care because of the number of patients they're trying to deal with concurrently. But these patients outside of a window where your intervention of TNK or TPA is not on the table any longer, but they just need to get to the place where EVT can be done, and the EMS personnel are appropriately trained and able to do advanced or FASTs or other assessment for high probability LVO. Having those patients bypass is a fantastic idea.
Yeah, I just want to say that stroke is a team sport. It takes everybody being on board with how to do it best. That's pre-hospital, it's emergency medicine that includes nursing, techs, transport, physicians, everybody, and also system-wide with hospitals that are sending hospitals, hospitals that are receiving hospitals. It's really helpful to do QI. It's really helpful to look at the cases that you've had over the past month or 2 or 3 months. Do it quarterly, do it monthly, and learn from each case. Stroke can be very complicated. Each case is very different. It's really nice if you can have your endovascular neurosurgeons come and do some QI and look at each case and see what happened to them, see how they did, what happened with the patient. Did they do thrombectomy? Was it successful? And have that whole team, everybody's in on it. This is a really complicated area. The imaging and the studies looking at how far we can push the window are happening so quickly. And I think it's challenging for emergency medicine to stay on top of all the studies and everything that's happening in the world of stroke, because we're also needing to stay on top of the studies and everything that's happening in cardiology, respiratory, and everything else. So it's really, it's helpful to have that team approach to it and to embrace QI and to say, hey, come down, look at our cases and go over them with us. I think if I can say from the tertiary care center perspective, we often see some things that we say, oh, this could have been better, but we don't have the window to approach that because many times it would be perceived as the big dog coming down and telling us what we did wrong. But that's not really what we want to do. What we want to do is just make patient care better. And I think if there's a two-pronged giving and receiving of quality improvement information, we can make this better. And we can learn in the process. I am always learning from my stroke neurologists every single day. And it's always a conversation. And so I would encourage folks who are listening to this, if you're part of a system where you don't have that resource in-house, look for QI, ask for it.
Completely agree. I think, that comes back to, as we talked about briefly, the idea of what SimKit is about in preparing, right? Preparing for, these are not actually that uncommon, that infrequent, but if we don't have the systems in place, don't have a mental model and a shared mental model with our tertiary center, we're going to set ourselves up for delays and misses and misadministrations and all the above. So, Evie, if I may, I'm going to do a summary and have you weigh in at the end. How's that sound?
Sounds great.
Awesome. All right, so we were joined obviously by Evie Marcolini, an ED physician as well as a neurocritical care doc, to talk about stroke and the management of it in the community setting. A fair bit of our conversation actually surrounds system-based practices and best practices in that. The example that I gave was an elderly lady who came in at 3.5 hours and how we manage her in the community hospital or the freestanding ED. Ideally, we're getting a system in place where our EMS personnel can alert us so that we can be ready. We need to be ready as providers with our charge nurse, our techs, and our CT tech. If you can have a system where they do a stroke stop or giving report, someone is calling to hold the CT scanner so that you can do your initial assessment. You're going to do a modified version of a neuro exam and really in my mind, a lot of this is focusing on the realm of LVO. Evie uses the VAN score, I use the FAST-ED score, whichever your system has adopted, making sure that you're ready and able to do that at bedside. When you complete that exam and you see signs for a stroke and you're verifying that we are within a window, then you're doing your processes or putting them in place to get the imaging ordered that you need, and the additional generally should be order set based process for things like the blood sugar, the serial vital signs, the EKG, etc. I love the idea of working with our EMS personnel who both alert us of the patient coming in, and if we are seeing findings for an LVO, having them on standby for transport after we do our CAT scan. If they receive their thrombolytics, etc., they go up for EVT. We then started to get a little bit into the nuances of the NIHSS and how we think about numbers and patients. And I really like the global idea of it's the patient, their history, and what their deficits are and what they mean to them. When we make a decision about thrombolysis or not necessarily considering a true number on the NIHSS, but how devastating are the symptoms and how likely in the global picture of the patient, their past medical history, the ancillary information we're getting from EMS and family about what we're actually dealing with here. Are we confident that we're dealing with a stroke, or is there a higher probability of an alternative diagnosis? With that, documenting our thought processes in real time to protect ourselves medical legally. We're asking our thrombolytic questions. We have 3 in our system, but making sure, again, reiterating the idea of working with our tertiary center for the questions that we want to ask to make sure that this patient is indeed safe for TNK or TPA. After that administration is done, and if we see an LVO, we are hopefully getting them back on the same EMS rig up to the tertiary center. If not, we're working on trying to get rapid transport to these patients to the facility that's going to care for them best in the long term. How's that sound?
Jason, you have summed it up really nicely and hit all of the high points that I think are really important when we're thinking about stroke outside of the tertiary care center. The 2 things I wanted to add are, number 1, don't forget about the posterior circulation stroke. Think about the dizzy patient, understand the HINTS exam, understand that a posterior circulation stroke will be treated the same as an anterior circulation stroke with regard to systemic thrombolysis, and sometimes will warrant thrombectomy. Many of them are also dissection, and we need to find those. Those are can't miss diagnoses. And the last thing I wanted to say is I've had so many questions and conversations with folks about TPA, and I'm not one who argues the data and argues the validity of the data because I'm really not a statistician. But I do want to say that this becomes an ethics issue for me. And when I think about TPA, I really don't think about giving it. I think about offering it. And we should be offering this to our patients. And that means we need to be consenting them for it. And what that means is we need to be able to explain stroke in an understandable way to our patients so that they truly understand the risks of TPA and the benefits of it, and the risks of not taking TPA and the benefits of that. That is the art that I think in emergency medicine we are very good at. We are very good at approaching a patient and getting to know them as much as we need to in the first 5 minutes so that we can figure out what do they understand, what can they understand, and how can I explain the risks and benefits to them. We're really good at that because that's what we do all day, every day. The other part of it is understanding how to figure out what their risk-taking propensity is. Everybody's risk-taking propensity is different. Yours might be different from mine, and we need to respect that. But we understand how to talk to patients and get at that. We do it every day. And I think if we approach the question of systemic thrombolysis from the perspective of we should be offering TPA to patients, it really does put a different feel to it than we should be giving patients TPA.
Yeah, I love that structure and that sort of mindset of offering it. And yeah, we're not going to get into the can of worms about TPA, TNK collectively as we wrap up, but I think if your understanding of the literature and hopefully if you're forming a strong opinion, you've read it, and you're doing an informed consent with that in mind, then you're doing best by the patient, right? You can talk to them honestly or earnestly about how about the data that's out there. And we're doing that in concert, of course, with our neurologist. If we're going to have that conversation, and certainly if we're giving these lytics, then we are going to be working with them very closely. But if you are informing them, you're doing that with your full spectrum of knowledge. And that, I think, addresses this relatively sticky issue. But the idea of offering over giving, of consenting rather than just treating without full understanding of their disease processes and the risks and benefit, I really love that approach. So thank you, Evie.
Thanks for having me.
Yeah, it's been a blast. We'll have you on again. And everybody listening, thanks for joining us today. And I hope that we've helped inform your care of patients who present to your remote access, freestanding, or other community hospital with signs and symptoms of stroke. Until next time.
Don't forget, SimKit is here for all of your procedural training and high acuity, low occurrence procedures. Check out the link below and use this coupon code SIMKIT10 for 10% off.